Hi, it's Dr. Robert Seichert. Thanks for tuning in to a brand new episode of the Doctor Podcast Show. We really appreciate your tuning in. And please subscribe and follow Doctor Podcasts. And if you like this episode, and I'm sure you will because it's very interesting, please click on the like button and repost it. And please send comments as well. We'd really appreciate that. Today we have a great guest. We have Dr. Samantha Dunham. Dr. Dunham is a clinical associate professor of obstetrics and gynecology at the NYU Grossman School of Medicine and the NYU Langone Medical Center here in New York City. She's also the co-director of the Center for Midlife Health and Menopause at NYU. And today we're going to be discussing menopause, which is very important, affects hundreds of millions of women around the planet and the men who live with them as well. So Samantha, thanks very much for coming today. I really appreciate you taking the time from your busy schedule to come and speak to us about menopause, which is a very important issue. As you know, I'm an ophthalmologist. I have many patients who are in the age group of menopause, and many of my female patients complain about all sorts of menopause symptoms. They especially are known to have dry eyes. They get that as a problem related to menopause, so it's a big problem. You're a menopause expert, but tell us about your background. How did you get interested in obstetrics and gynecology after the 4 years of medical school?
Sure, yeah, thank you so much for having me today. So I became interested in kind of gynecology, OB and GYN during medical school, and I knew I wanted to pursue women's health in medical school, and then did my residency in obstetrics and gynecology. And then eventually just practiced gynecology only, which morphed into a really focus on menopause, which is where we are today.
Right.
Yeah.
How many years of training post-medical school does it take to become a gynecologist obstetrician?
So it's a 4-year residency.
4 years?
Yeah.
And then how did you become a menopause expert? Is that extra training or you just decided to?
It's really a clinical focus, a clinical interest, and there's also certification and kind of special training through the Menopause Society. But it's really like a clinical specialty, clinical focus.
So there's a menopause society, that physicians and doctors who take care of patients?
Yeah, it's quite broad actually. It includes like physical therapists and nurse practitioners and pharmacists and all sorts of different health providers.
That deal with menopause issues?
Just interested in menopause and the midlife.
That's great. Very, very important to do that. Tell us about what menopause does to a woman in that age group. What kind of physical symptoms do they get?
Sure. So menopause happens any time between the age of like 40 and like 58 on the outside. And it's accompanied by a lot of different physical changes. So some of the physical changes we think about are things like, the most obvious is really a change in how the cycle is, how the menstrual cycle is. So that's a sign, and people recognize that instead of having a regular kind of monthly menses, they have irregularity in their period, so it's a physical sign. But then there's lots of physical symptoms that people have, like vasomotor symptoms, hot flashes and night sweats. Sometimes people get heart palpitations. Joint aches are becoming more recognized as a symptom of
joint aches.
Joint aches, yep. It's actually like a musculoskeletal syndrome of menopause. It's got a new name. And also vaginal dryness is another physical symptom but that's called genital urinary syndrome of menopause because it affects the vagina and the bladder.
So it affects
some of the physical signs.
Affects different organ systems in the body.
Yeah.
And it's different in different women.
Absolutely. So symptoms really vary, and not everyone has symptoms. Like some people barely have any of the symptoms. Everyone's period stops at some point, but many, maybe 15%, 20% of women don't really feel anything. They just notice a change in their cycle. And they don't have that many symptoms, like very, very minimal.
But then that means about 80% do
80% do have some, some sort of symptom, yes. And it's a grab bag. Like we can't predict what kind of symptom they're going to have. And besides the physical symptoms, there's also sort of emotional symptoms too, like irritability or sometimes anxiety, sometimes rage, and then there's also brain fog that can happen. That's really common in the perimenopause and menopause.
Brain fog.
Yeah,
So
brain fog.
you're like forgetful, or
Yeah.
you're just not thinking that clearly?
More of a problem with word recall. So like the verbal processing becomes different. And it drops just a little bit from like the high function that most people are to just a little like a difficulty in recalling mostly nouns.
Nouns.
Nouns, sometimes it's just the word's just out of reach. But that goes away, after the brain kind of adjusts to having less estrogen over time. Usually that calms down.
I see. Now, I've heard of the term perimenopause, and then there's menopause. Can you explain the difference between those two things?
Sure. So peri really means around menopause, and menopause is when after someone hasn't had their period for a year. So there's like one day, that's actually where menopause is recognized. So they look back and say, oh, their final period was a year ago, and now this is menopause. So everything around that time is perimenopause.
I see. So first they become irregular, the periods, and then eventually the strict definition is no period for about a year?
For a year, yep. And then any bleeding after that is really not normal. So, and perimenopause can last about 4 years. It may last 8 years. It's a really long time, and it's sort of an unpredictable time.
Right. And it's different for different women also.
Yeah. Symptoms show up in different ways, sometimes with sleep disruption. Mood is common, so exaggerated PMS. Sometimes migraines occur, the headaches happen, yeah. But, these things, as the period comes to an end, they often get better.
You mentioned the vasomotor and the hot flashes. Why is that called vasomotor?
Vasomotor symptoms, it just describes the change in the kind of regulatory process of temperature regulation. So like the thermostat in the brain becomes kind of dysregulated, so that there's a very narrow comfort zone, and it's like the word that describes these symptoms, which are hot flashes, which are the hot flashes that happen during the day, and then night sweats, which is the same phenomena, but at night.
So the temperature control of the body from the brain becomes irregular and kind of unpredictable.
So with the loss of estrogen, it becomes just less controlled, so that different things can set off hot flashes, and sometimes for no reason, hot flashes happen.
Right. And that can happen during perimenopause and menopause?
Yeah. So
symptoms?
So it's common in the year after menopause, but it also occurs in the perimenopause.
I see. And is the temperature actually elevated if you were to check the temperature of somebody who's having the hot flashes or the sweats?
They feel hot, but the temperature is normal. Yeah.
Temperature is normal,
Yeah.
so that's how
But the skin can feel warm.
The skin can feel warm. The emotional symptoms, again, do all women experience that, or is it in some women?
It's about 40% of women in
40%,
perimenopause.
so pretty high number.
Pretty high, yeah. And women who've had a lot of PMS earlier in their life are more likely to have symptoms at perimenopause. So, and people who've had postpartum depression or other kind of hormonally driven mood change throughout their life, they're more susceptible to having the mood changes at the perimenopause, especially in the late perimenopause.
So if you've had any psychological issues in the past, you're more prone to those emotional swings?
Yeah, like PMS or PMDD, which is the very exaggerated form of PMS, or postpartum depression, which is really severe depression with almost psychosis right after delivery. Those women are more susceptible to have really big mood changes at the perimenopause and menopause.
What percentage have these severe emotional symptoms? Is it also a large percent? Or?
I don't know. I don't think it's that large.
It's not.
Yeah.
So it's a
yeah,
relatively
it's
small number.
Right. Yeah, for the severe.
Right. Now you mentioned estrogen a couple of times. That's the hormone that's responsible for this. Tell us what estrogen is and how you have it in your younger years, and then what happens? Why do estrogen levels go down?
Sure. So estrogen's made by the ovaries, and estrogen's made during ovulation, like throughout this cycle of like the monthly cycle. So during perimenopause, the cycle becomes irregular. So estrogen levels become kind of less predictable. And then over time, as ovulation stops, estrogen levels fall. So most of the time in a woman's life, there's a normal, predictable, range of estrogen up and down, up and down. And then at the time, and also progesterone is another hormone that's made by the ovary. And then at the time of menopause, those levels really drop, and sometimes they drop, almost abruptly, along with progesterone, and then that causes the symptoms, or causes most of the symptoms. So, because there's estrogen receptors throughout our body, so people's, the skin changes, the heart's sensitive to estrogen. There's receptors everywhere. So
that's why it affects the whole body
Yeah.
when your estrogen levels drop.
Yep, exactly.
What about the progesterone levels? They also drop, and is progesterone responsible for some of these symptoms as well, or is it mostly the estrogen?
We think it's mostly the estrogen. Progesterone, when we give people medication for to help with symptoms, like we talk about a lot of different options for treating the symptoms, but in terms of hormonal medication, we offer estrogen, which helps with almost all the symptoms. And if somebody has a uterus, they need to take the progesterone or a progestogen to prevent the uterine lining from building up from taking too much estrogen. So that's where the progesterone comes in later. But in terms of like progesterone helping symptoms, it does help with sleep because progesterone is kind of a comfortable hormone. So, if people take it before they go to bed, it does help them sleep.
Right. So now that we understand what causes this and why it happens and so on, what are the treatments that are available for treating women who have menopause?
So treatments, well, it depends on what their symptoms are. So in our clinic, we do kind of a deep intake with, people do a rating scale, and we get a sense of what's bothering them the most and sort of tailor our treatment according to their issues. Right. If it's something like vasomotor symptoms, then we have a lot of data on what works for vasomotor symptoms, and the gold standard really is estrogen, with or without progestogen, according, if they have a uterus or not.
So if they have a uterus, if they haven't had a hysterectomy, then you also have to give them the progestogen.
Progestogen, exactly. And then there's other non-hormonal treatments too. And there's also complementary therapies. So we talk about cognitive behavioral therapy. Weight loss helps with vasomotor symptoms. Hypnosis helps. Hypnosis, yes.
Wow.
Who knew?
Right.
Right.
I guess that affects the way your brain functions.
Yes.
So
yeah.
It can affect mental issues that occur.
Yes, exactly. So we just tailor our, treatment plan according to what the patient wants to do and according to what's safe for them, and what their symptoms are.
Right. Now, I've heard over the years that there's been controversy about whether giving estrogen is safe or not. In fact, many of my women patients who have menopause and complain about it, I sometimes will ask them, are you taking replacement, HRT, hormone replacement therapy? And they go, no, I heard that's dangerous. Is that true, or is that a myth, or what's the story about that?
It is a myth, actually. And it's a myth. And it comes from a study it's over 20 years old, that looked at was looking at like longer term health outcomes, like cardiovascular outcomes for women, and also bone health for women, and some other endpoints. But in this study, they looked at women who were taking estrogen and women who were taking estrogen and progesterone. And the study's mean age was 62 years old. So they enrolled women from their 50s until their 70s. And they found that there was They stopped this study early in the course because they found increased risk of cardiovascular disease, and they found increased risk of breast cancer. But they didn't look at, later analysis showed that the younger women didn't have these increased risks. So there's a theory really, which is called the timing hypothesis, that if women start hormones early, like close to the time of their menopause, that it's actually protective against cardiovascular disease. So at least in that first decade. So it sort of turned that on its head. This study happened to use an estrogen called Premarin, and it showed a decreased incidence of invasive breast cancer as well, because they followed the women over time and they saw a statistically significant decrease in the risk for invasive breast cancer. So it's given us a lot of information, but at the time it was released to the media before it was released to physicians, and it was a huge it was a huge uproar. So hormone use fell off, and I think the medical community was unprepared to counsel people because it wasn't kind of well presented, right, or well understood.
So have there been subsequent studies of good quality? And
there's been nothing of that scale, like because it was a massive study, and there hasn't been anything that's really replicated. But there's been lots of observational studies since then, looking at kind of estrogen and progestogens, and estrogen as a whole seems to be neutral in terms of breast cancer risk.
Okay.
So,
what about uterine cancer or cervical cancer or other cancers?
Yeah, so no link to cervical cancer.
No link.
And if estrogen's taken unopposed without the progestogen, it can increase the risk of endometrial cancer.
Okay.
So it's important to take the progestogen with the estrogen. It also showed a decreased risk in colon cancer.
Really?
So,
Colon.
yeah, estrogen and progestogen. So there's some benefit there.
Right. Now, should women who are getting estrogens and progestogen be screened for cancer at an increased frequency, or the same as anybody else in that age group?
Yeah, well, the same. I mean, it's important that people stay on top of their mammograms, right? Like every year they need to have an annual mammogram for breast cancer screening.
Above what age every year?
About 40.
40?
40,
Okay.
mm-hmm. And I mean, most people who are taking hormones are in their late 40s.
Right.
So, and the theory there is, if they had a tiny breast cancer and they were taking hormones and it was an estrogen receptor cancer, it would probably grow faster. And that's what they did see in the that Women's Health Initiative study, that the women who did develop cancer were detected at an early stage and actually had a lower mortality rate. So we want people to, do their annual screenings regardless, but especially if they're taking hormone therapy.
Right. So just the regular screenings.
Yeah.
What about how long can you take the estrogens and progestogen? Is there a time limit for how long you can take that safely, or it seems to be safe indefinitely?
Yeah. It has other benefits. So it has the benefit of reducing risk for fracture. And osteoporosis is a big deal for women as they age.
Now, osteoporosis is a weakening or a softening of the bones, right?
Exactly.
And that starts when menopause starts.
Yeah,
right?
that starts really around the time of menopause.
And if you take the estrogens, then that
it stabilizes. It stabilizes. Yeah, and prevents like future loss. So people can maintain what they have. But in terms of timing, it depends on the patient and depends on what their symptoms are like. I mean, the average symptoms, really last up to 10 years for Black women, and shorter for some Asian women, more like 5 or 6 years. So it depends on the patient, but they could be treated for as long as they have symptoms. And then after that point, they can decide if they want to continue or not. Sometimes we look at a bone density, make sure they're up to date with their mammograms and up to date with other screenings, and that nothing else has changed in their health history.
How do you know when to stop? Do you slowly taper the dosage, reduce it, or you just kind of stop it, cold turkey, see what happens?
You could try either. I mean, it's
way?
kind of 50-50, yeah. And I mean, half of the time symptoms come back and half of the time they don't. So most people taper because it's a little more comfortable to taper. But people also just stop and they can feel fine. there's no right or wrong.
Right, so you try it and see what happens.
Uh-huh.
Now, it turns out I think women have a reduced incidence of heart attacks until they go into menopause, and then they catch up to men who have an increased risk of heart attacks. Is estrogen protective for getting heart attacks in women?
So yeah, it's right. It's true that at 50 years old, women are a much lower risk for heart disease. But then, as I think we equal a man's risk at 60, and then I think we surpass or come close to it by 70. So our risk really starts to accelerate. But estrogen does help protect the vessels, so it keeps the vessels elastic. And depending on when someone starts hormones, it maintains the idea is that it should maintain the vessels as they are. So it helps prevent, it just stabilizes the vessel.
So what happens with heart attacks is the coronary arteries in the heart kind of get clogged up and get harder, and they're prone to blockage, and then you get the heart attack. So you're saying that estrogen kind of keeps those blood vessels in better shape or younger shape?
Yeah, right, exactly. Yeah.
Seems to me, I'm an ophthalmologist, I'm no expert in this, but it seems to me like there's very little downside to treating with estrogen and or progestogen. Is that correct? I mean, what are there significant negatives to treating with estrogen?
Yes. Well, we know that for estrogen and progestogen, there is an increased risk of breast cancer over time. So it's not a big increased risk, but it's there. So about an additional three women in 1,000 develop breast cancer over 5 years. So, that's one thing.
0.3%.
Yeah,
roughly.
it's low, right?
But if you have your annual mammogram screenings, that should be picked up,
it
right?
should be picked up, exactly.
So the risk is higher if you don't have the mammogram screenings when you're on the estrogen.
Right. So there are multiple benefits, but I don't think there's any one drug that fits everybody. So I think the only people who have to think twice about, or we counsel them strongly about taking hormones, are people with family history of clotting disorder or themselves with a clotting disorder, because estrogen does increase the risk of DVT. People have history of
blood clots in the legs that travel up to the lung, cause a pulmonary embolus.
Right. So we talk with them about the mode of how they would take estrogen, if they would be able to take estrogen if they had to.
Right.
And then people have history of heart disease. People have history of stroke, and people have a tendency to clot. So, and then also women with breast cancer, if they've had an estrogen receptor positive cancer or any breast cancer, then that's they're usually not candidates for hormones.
Right.
Usually, but there are always exceptions.
Yeah. Right. You have to
it's very individualized.
Every patient.
Yes, very
separately.
individualized.
That's why you co-direct the center and figure these things out at NYU, right?
Yeah. Right, we have a lot of complex patients who come in looking for solutions for their symptoms and problems. So,
right. Are there different types of estrogen, or is it just generic estrogen? And do some work better than others?
That's a really good question. So there's there's estrogens in general. So there's there's conjugated equine estrogen or conjugated estrogens, which is Premarin, and then there's estradiol, which is another kind of estrogen, and then there's others that aren't commonly used in the U.S. but that are in other countries and kind of sold as compounding pharmacies too. But the ones we use typically are estradiol, which is really a metabolically active estrogen, and then Premarin. So we know a lot about Premarin from that randomized controlled trial, and we know a lot about estradiol just from observational trials over the years.
Are they roughly equivalent in safety and effectiveness?
They are. Premarin's only available orally, and estradiol is available orally and transdermally. And the benefit there is we avoid that first pass in the liver. When something's used through the skin, it doesn't get metabolized through the liver, so it's just less kind of wear and tear on the liver. So it has a different profile for safety.
And what about the progesterone or progestogen? Are there different types?
Yeah, there's different types there too. So often we use something called micronized progesterone, which is like the kind of body identical progesterone. It's called Prometrium, and that's an oral tablet, an oral capsule. There's also there's a patch that's available with both estrogen, the estradiol plus there's two kinds of progestogens that are available in a patch.
So it's a skin patch. You put on your
Transdermal
skin.
patch, and we use an IUD in the uterus, which is a wonderful way to protect the lining of the uterus, which is the levonorgestrel, another kind of a progestogen that we use in the uterus.
I see. So that's put into the uterus and it slowly releases over time?
Yep, it's over 5 years.
5 years?
5 years.
Wow.
It's a beautiful option because they don't have any systemic exposure to the progestogen. So we avoid the breast exposure in that case, and people can use the estrogen as they want.
Seems like a
It works.
very effective way to do it.
It is.
What about, there's a new drug I think was approved about a year ago specifically for the vasomotor, hot flash, sweating symptoms. Can you tell us about that?
Sure. Yeah, that's a medication called fezolinetant, and it's called Veoza is on the market. And it was about a year ago, I think in June, and it works in the brain, so it's non-hormonal.
So it's not an estrogen or a progesterone derivative.
Exactly. So, and it affects a specific neuron that talks to that thermoregulatory center in the brain. So we've been using it for about a year, and for people who can't take estrogen or don't want to take estrogen, who are really in menopause, it's a great option for them.
And it works well from your experience?
Yeah, it works along the lines of some of the SSRIs, SNRIs that we use. So, it's about 60% effective, but it reduces the frequency and severity of hot flashes.
And is that a pill or transdermal?
It's a pill.
It's a pill, and
it's
you
a
take
pill.
it every day?
Yeah, yeah, it's got a very nice safety profile. So,
Any significant adverse side effects from that?
well, while they're taking it, they do have to check liver hormones or liver enzymes every 3 months, just out of abundance of caution. But I think the biggest side effect seems to be like headache and abdominal pain. But it's pretty low, like less than 3% of people have that.
Oh, very low.
Yeah.
Do some women need to take the estrogen plus the Veoza to get total relief from their symptoms?
Yeah, we can't layer those because of how they're metabolized.
Oh,
so
it's one or the other.
It's one or the other, yeah.
Does the estrogen get rid of the vasomotor symptoms too? The flashes and the sweating?
Yeah, for
It
sure,
works well.
yeah. And that's, that's sort of been that's the easiest thing I think to study is the hot flashes. So it's been really well studied, and estrogen is definitely the preferred route there because it's so effective.
Right. What about the, you mentioned the psychological problems, mental health issues. Are those also helped by the estrogen?
So in the late perimenopause and the very early menopause, it can help. So sometimes the vasomotor symptoms are accompanied by a feeling of anxiety. And in that case, especially the estrogen or hormones work really well. So it can help, definitely.
Right. Now, you mentioned the SSRIs, which is sort of antidepressants. Which one do you use?
So Paxil or paroxetine is the one that's FDA approved, but we use others as well. And they work at about 60% of the time. They work really well.
And those can be taken with the estrogen simultaneously?
Yeah, they can. And we use really low doses, and they're effective. And for these kinds of medications, the side effects like weight gain and loss of libido tend to be dose related. So for the low doses, people do pretty well without side effects, and they often have relief from their hot flashes and night sweats. Right. And sometimes they have some mood benefit
as well. How often do you have to refer these patients to a psychologist or a psychiatrist for more intensive treatment?
We reach out all the time. I mean, we have,
So it's a team effort.
It's a team effort, yeah. absolutely. So we connect with other, there's telepsychiatry or teletherapy.
Right.
So we have some connections in the teletherapy world, and we connect our patients with teletherapy.
Right. Now, you mentioned earlier about osteoporosis and bone health. So when menopause occurs, there's a tendency to get the softening of the bones or the osteoporosis.
Uh-huh.
Do you recommend women take extra vitamin D and calcium to help with that?
So that bone loss happens around the time of menopause, and it can be like 15-20% of their bone density. So during that time, really up in, from the age of 50 on, it's recommended they have 1,200 milligrams of calcium. And then vitamin D has to be adequate, so that can be tested with their blood. And if it's not adequate, then I recommend a supplement.
You have to give that.
Yeah.
There was a report or two, I think a couple of years ago, that taking extra calcium may increase the risk of heart attacks because it may accumulate in the arteries in the heart. Is that certain,
Yeah.
or is that just a theory? Or
I don't know if it's certain or not. I think it's theory. I mean, we know that calcium is really best absorbed through food, or beverage. So we counsel our patients to take it through diet, if possible. And if they are osteopenic and they do need a supplement, then I think they do need to supplement. But diet's always better because of how it's absorbed in the system.
Right. Now, you mentioned earlier about sexual health and the effects of menopause. Tell us about that and what you do for that, how you treat that.
Yeah, so that's another area that comes up all the time, the genital urinary syndrome of menopause. And a lot of people have an issue with vaginal dryness. They have pain with relations, and it's from the decreased estrogen where the tissues become kind of more delicate, and people experience more frequent urinary tract infections or urinary frequency or just discomfort. So it's easily treatable. We offer vaginal moisturizers as a first line. We offer vaginal estrogen, which is really, really safe, really effective, and usually helps them tremendously. So, and it becomes if they don't get treated, that problem really gets worse. So we encourage people to talk to us about it, and then get treated.
Right. And there's no increased risk of cancer from that?
Right.
As far as we know?
No. Very clearly, no increased risk of cancer because the blood levels really don't increase above a postmenopausal level for estrogen. And there's no need to take a progestogen with it, so it can just be taken on its own. And long term, it's wonderful for even older women who may have urinary tract infection and don't even know they have a urinary tract infection, help decrease that risk.
Sounds very beneficial with almost no downside.
I agree. Yeah, really.
Right.
Yeah.
Now, what about lifestyle changes that women can make to help with the menopause?
So one of the major things that almost everyone experiences is weight gain in the perimenopause and menopause. And it's, no one's exactly sure why it happens, whether it's just hormonal shifts or, we have this loss of kind of lean body, lean muscle mass, and then increase in adiposity. So our metabolism changes. And it's, also women become less active, maybe their eating habits change. It's harder to get the food that they want, and there's so much processed food in our food supply. So we talk a lot about nutrition, and we're now working with a nutritionist through NYU along with an exercise physiologist and referring people there for support with nutrition counseling. We talk about exercise, we talk about weightlifting and weight-bearing exercise. We talk about just being active in your downtime, so to maintain that level of activity.
Right. Yeah, no matter which doctor I interview, no matter what the specialty, they always tell me exercise is really helpful in treating everything. Do you find that as well?
Yeah, absolutely. So, and we know for bone health too, it's a big deal.
Right. It deposits calcium in the bones.
Yeah.
If you exercise and lift weights, it actually takes calcium.
It feeds the bone.
Right. It feeds the bone.
Yeah, completely. So, and then longer term, we think about balance exercises and agility, things that prevent falls. So, we start early. We start talking about it when people are in their 30s and give them the heads up that they can start, to build that muscle and be strong going into their perimenopause.
Right. I read recently there are some companies working on some drugs that may actually prevent menopause completely. Is that close, or is that kind of years away?
It sounds like magical thinking. I mean, it sounds like really wonderful, but I think it's years away. But there's there's obviously work in that direction because it would be great to kind of lock the ovary in time, so it continues to make hormone. But I think we're unfortunately a long way away.
It doesn't continue to ovulate and create eggs. It just continues the hormone
to make estrogen.
production?
I'm not sure how it works. Yeah.
Right. I think that's maybe a few years away.
A few years away, yeah.
You never know.
Oh, right. Maybe, we don't know.
Right, have to wait for the results of the clinical trials. You do research and teaching at NYU as well?
Yep,
Tell us about that.
Yeah. So in our clinic, we have the fellows with us. They rotate with us while they're doing their menopause.
So these are fellows in what specialty or subspecialty?
They're in reproductive endocrinology. So, and they just spend some time in our menopause clinic. In the OR, I'm still practicing gynecology. I see medical students, and I also see residents, where we talk about everything hormonal, even though we're doing hysteroscopies.
Right.
So that's how we interact with the graduate medical staff.
Right.
Mm-hmm.
So you're busy teaching, which keeps you on top of all the latest developments.
A lot of questions, right.
Right. What about clinical trials? Are you involved in any clinical trials?
If we get funding, we have a randomized controlled trial coming up that looks at exercise using a certain app versus exercise without using an app. So it's sort of a comparison, because often we tell people, do this exercise, and it's such a general blanket piece of advice.
Right.
So it's the idea of like giving them something specific, looking at some metabolic parameters and body composition changes to see if that's effective or not. So
it's interesting. If you have your phone tell you to do exercise, you tend
maybe we'll do it, but pay attention.
Right. The phone says I should do exercise, whereas otherwise you say, well, I'm going to have a hot dog.
Yeah, right. Or maybe get a gold star at the end of the day, right?
Right. What do you think is the future for menopause in the next 5 years?
I think perimenopause is really having a heyday. I think there's a lot more interest in perimenopause. Because it hasn't been, I don't think we know as much about it as we could. So I think that's going to kind of get the focus soon. And then I think menopause is becoming less stigmatized, as more people are talking about it and more people are just more open about it. So we've seen Halle Berry on Capitol Hill. Oprah's talking about it. There's a lot of, it's in the zeitgeist right now.
Right, which is good. You mentioned earlier the weight gain issue. Are you seeing patients taking Ozempic or Mounjaro because of the weight gain?
Yeah, some. I mean, I think it depends on their incoming BMI about how they're counseled for that. It's not something I prescribe. But
so
for
you
sure,
would send them to an endocrinologist if they want to take
I'd send them to
Ozempic or Wegovy or Mounjaro?
Right, or to a weight loss clinic. So if they're interested in that, I'd send them to talk about it.
Does the estrogen prevent the weight gain, or not really?
Estrogen helps with kind of redistributing the weight, so it doesn't it doesn't settle as much in the belly.
I see.
So which is better for the risk of the visceral fat forming.
Right.
So estrogen helps in that regard. It is not associated with weight gain. So it's helpful for someone who's trying to be more fit.
Right, that's great. So what I've noticed, and from what you're telling me, a lot of my female patients who are in menopause have lots of misconceptions about it and lots of myths. What types of things do you hear from patients that are misconceptions and myths and lead them to not get treatment or the wrong
Yeah.
kind of treatment?
Well, I think it's people come in with a family history of breast cancer, and they're really afraid of hormones from that perspective.
Right.
So that's, I think, a myth where we really have to talk about that, and they have to be comfortable with their medication at the end of the day. So I think that's a big myth. I think, and other myths are just like that you have to stop hormones at a certain point in time. Because it's really individualized. I don't think there's an automatic stop for anybody. At a certain point, it probably doesn't make sense to keep taking them, but it really depends on the person. So it's something that's to be evaluated year by year.
Right. So a lot of primary care physicians take care of women in that age group. Some of them may not go to their gynecologist at that point anymore. Are primary care physicians, like internists and family practitioners, being educated about the role of estrogens and the new drug Veoza to help their older women patients?
I think it's yes. I'd like to say yes, but I mean the education has to come from the practitioner themselves,
Right.
because it's often not taught heavily in medical schools.
Right.
I mean, there's a kind of pull back after the WHI study 20 years ago. So it's slowly, I think, gaining ground. But I think patients are pushing their doctors to learn about it and to be more responsive. That's what I hear from patients. So I think, and doctors are becoming, so it's certainly easier to prescribe Veoza for some people than it might be to prescribe hormones because of the just the cultural weight of hormones. But I think it's changing. I think people are becoming more open, and I hope people are becoming more open. And I think this generation...
I think it has. It's a topic that was like taboo and nobody wanted to talk about it years ago, but now it's more out in the open.
Yeah.
The media has helped in that respect. While it's negative in some ways, it's helpful in other ways.
And I think the patients are demanding. I think they aren't going to take the... I think they're not taking the brush off anymore, and they know that they can find an answer if they push hard enough.
Right.
So, which is great when they advocate for themselves.
They just have to find you and get to you to get the proper treatment.
Or any, menopause there's a menopause certified practitioners, so they have to find somebody who's familiar with prescribing.
What's the name of the organization so people out there can look it up on the website?
So it's called the Menopause Society, and on the society you can locate your practitioner by zip code and search for somebody in your neighborhood.
So you go to Menopause Society, put in your zip code, and you can
find a practitioner. Yep,
right.
Absolutely.
That's terrific. Well, this has been very educational and informative for me, and I'm sure for the people out there as well. I really appreciate your taking the time to come today and teach us about this important topic, which will help lots of people.
Thank you very much. Thanks for having me.
Thanks.
Thank you.
My pleasure. Thanks. Okay.